Hi, good evening. I'm Dr. Gary Howsam and I'm Vice Chair of External Affairs at the RCGP. I'd like to welcome you all this evening to the latest in our series of panel events that the RCGP's been hosting for our members. This week, we'll be talking about research during the pandemic. You can put your questions to us at #TeamGPLive on social media or write them in the online members forum. If you haven't watched one of these panel debates before, then these sessions are all about giving us the opportunity to speak directly to you, our membership, about the hard work we're doing on your behalf and on behalf of our patients. So, on to tonight's topic, research in the pandemic. It's never seemed more relevant to current affairs or to medical practice. Right now, we're at the forefront of fighting a disease that's having a massive impact on each and every one of us and the way we're living our lives. However, some members might not be sure of how they can get involved in that research or what primary care research means. So what we've done tonight is pull together a whole host of people from across general practice and across the academic community to come and talk to you and tell you their stories about how they've got involved in research and the great work that they're doing at the moment. I'm not a researcher myself, I'm not an academic, but I've become more involved in research purely because of the pandemic and because of my role at the college. We're also making every effort to be more inclusive at the college. You'll notice from the panel tonight that we're not particularly diverse group and not particularly representative of the large number of folk that work across general practice in the UK. So I'll be asking the panelists directly about that too. I'm particularly interested to work out how we can get research out into those areas of general practice where perhaps it hasn't traditionally been seen before, and also those areas where people might feel intimidated about dipping a toe into the world of research. So I hope by the end of this hour, you'll have a much better idea of what the college is doing, what our academic colleagues are doing, and what that means for frontline general practice. What I'll do is ask each of the panelists to introduce themselves and their institute when they come on and speak to us. I'm afraid it's a bit of an acronym soup, but I'm hoping by the end of it, we'll have a better understanding of what all those acronyms mean too. So I'm going to kick off and go straight over to our first panelist, Phil Evans from the NIHR, about his work. And Phil, an easy question to start with. When are you going to have this vaccine ready for us?
Oh, thanks, Gary. Thanks for having me on board. Thanks for giving me the really tricky question to kick off with. So I'm Phil Evans. I'm an academic GP down here in Exeter, and I'm Associate Professor of General Practice in the University of Exeter in the Medical School. But I'm also the National Specialty Lead for Primary Care for the NIHR CRN. So apologies for the acronyms. That's the National Institute of Health Research, which is the body that's funded by the government to undertake health and social care research in this country and has been right at the fore in the pandemic. So I lead for primary care across England for the Clinical Research Network, or the CRN. My job is to facilitate studies that are going right across England through the 15 local research networks. So it's been a challenge to get studies up and running so quickly in the pandemic, and the UK has really risen to the challenge, I think, and the vaccine studies are part of that. So we have about 60 urgent public health studies that are currently going on across England and now across the devolved nations as well. So it's great to see a UK effort. We've recruited just short of 200,000 people into those studies, either patients with COVID or risk of COVID. So it's been a great collaborative effort. As far as the vaccines are concerned, you know, there's an awful lot of vaccines around the world that are being put into clinical trials, but we're fortunate in this country to have a number of quite advanced clinical trials, and they're the ones that are going to give us the answer to the question that you just posed to me. So as Sir Patrick Vallon said on Monday, I think we're going to be expecting those vaccine studies to deliver towards the end of the year. But realistically, I don't think we're going to have a vaccine until the beginning of in the first quarter of next year, of 2021. There's a lot of imponderables about the vaccine studies. For example, whether they're going to work at all. I mean, some vaccines may not work. And the great thing is that the CRN that I'm involved in, we're testing those studies. I was testing those vaccines, all slightly different and all taking different approaches to the virus. We're testing those in large-scale studies in real-life settings right across the country. And it's great to see GPs engaged with that, as well as hospitals and other community centres actually across the country. It's a full-scale effort, this. So we hope that they'll demonstrate that these vaccines, or certainly some of them, will be safe and effective, and they have to be both safe and effective and then licensed to be given out by GPs and our staff once they're out and licensed and in routine practice. I don't know whether that answers your question, Gary. But
yeah, excellent. I think, as you say, Phil, there's a lot of anxiety out there from GPs. When are we going to expect this vaccine? And that's before we even move on to the question of how on earth we're going to deliver it. And I think we all appreciate the value of the research that's been happening up to date. If I can move over to Chris Butler, please. And Chris, why don't you tell us a little bit more, if you don't mind, please, about the research that's been going on throughout the COVID pandemic, and perhaps you could relate a little bit more about, have we learned anything about this pandemic previously, or about the way we've approached research in primary care during this pandemic?
Yeah, thanks, Gary. Well, thanks for having me too. I'm Chris Butler. I'm a part-time GP in the Cynon Valley in South Wales, and also clinical director of the Primary Care and Vaccines Clinical Trials Unit at the University of Oxford, and working closely with primary care research network throughout the whole UK. So to go back to your question about what we learned from previous pandemics. So the most recent one in our minds is the H1N1 pandemic, swine flu pandemic, and we gave Tamiflu or oseltamivir out by the truckload during that time. And I kind of see it as a national disgrace, really, that we didn't randomize a single patient during that time into a trial. We just gave this stuff out. And so therefore, to this day, we still don't know whether we did any good at all. And we know we actually did some harm because, people had side effects, and we missed seeing some people with pneumonia, for example. So that was a huge lesson for us, that what we need to do is to be doing trials within pandemics that generate evidence so that we can care for people with pandemic-specific data that we ourselves have generated in the context where we're delivering care. And that brings me on to the principal trial, which is the sort of flagship national public health trial labeled as urgent by all 4 chief medical officers in the UK, which every health and social care professional in the UK can get involved in and help people get into the trial. It's using innovative methods. At first, the trial was just, they say generals start to fight the last war. Well, we were doing this trial in a traditional way, recruiting only through general practices with GPs giving out medicines. And as patients are being seen in a wide variety of circumstances, we are now trying to bring the trial to where the patient is. And we've turned research on its head. We're able to recruit any patient anywhere in the country, regardless of where they're receiving their health care, regardless of their geography. People can help through the website, get the patient onto the trial, randomize them, and centrally we will courier out medication and follow them up online. Now we've got over 900 practices across the UK involved. NHS 111 is involved, the Zoe app's involved, but there's still a lot of GPs out there who don't know how easy it is to get people into the trial, and who haven't even heard of the trial. They don't need to worry about being burdened with huge amounts of paperwork. This is a paperless trial, won't take long to signpost people into the trial. And the follow-up for the patients is low burden as well. It's entirely paperless, as I say. And the type of person we're looking for is people with COVID-19-like illness, 50 and over with a comorbidity. People who are 65 and over without comorbidity can be in the trial. And if I can just make one last plea, Gary, this is a trial which really is the most sort of important trial for primary care at the moment, because we need to generate evidence that helps us care for our patients better. At the moment, so many GPs are prescribing things like doxycycline for these patients. Like with the H1N1, we'll never know if we're doing more good than harm unless we do that in the context of a trial. So please, easy to get involved, easy to signpost people into the trial, low burden for GPs, low burden for the patient, And we could be at the forefront of primary care research worldwide, put our discipline on the map internationally and generate critical evidence for our patients. We care better for them right now. So important questions for our discipline, and we can deliver if we get more buy-in, more people getting involved.
Brilliant, thank you, Chris. That was an amazing answer. And I mean, the bit that really resonated for me there, as I said, I'm not from a research background, but doing the research in the context of the place that we're delivering care is something for a frontline GP like myself, is something that's really appealing, and that easy accessibility and that low burden of paperwork and administration that goes with it. I think that's often put people off getting involved in research in the past, thinking it's going to be an additional bit to bring in. I wonder, Nick, do you have any views on that at all?
Yeah, great, Gary. Thanks very much. Yeah, so I'm Nick Thomas. I'm the clinical lead for research at the RCGP, and I'm a jobbing GP in Witney, West Oxfordshire. I do 3 full days a week seeing patients, work very hard, and we're having real fun in primary care right now, which I'm sure all of our colleagues are across the UK, with what's happening and with everything ramping up with COVID. And as our demand is very, very high. I'm finding it. I know all my colleagues are, certainly. But going back to principle is key. It's such an important study. I think we can't really voice how much we support the principle trial, how much the principle trial really should be there to enable us to find a treatment, to find something that will help our patients in COVID, and especially in early COVID, and prevent them from going to hospital, prevent them from getting worse. This is absolutely key to us. And as primary care, we've got this amazing opportunity to deliver what is probably I think Chris will probably correct me for this, but I think it's one of the biggest, largest acute primary care trials in the world, or soon to be that anyway, with the infrastructure that's in place, supported by the college, supported by the NIHR, supported by Pact, which we'll come on to later on, and our colleagues at SAPSI as well. So it's absolutely fantastic. I'm throwing a few more acronyms in there now, just for fun, Gary. But I think from my point of view, I recruited quite a lot of patients now into principle. It's brilliant. It's easy. It takes 10 to 20 minutes in maximum to do it. The main thing, the first 10 minutes, is actually just picking up the phone, speaking to that patient and saying, look, there's this amazing trial that's going on. We have to work together to try and find a response, find a result, and find a treatment for COVID. And this is the way we're going to do it together. Patients respond to that so well, so easily. They then pick the phone up to the research trial team, or they go online to principletrial.org. Quite easy to do. They then sign themselves up remotely, or they can phone the study team, and the study team will go through all with them then, check their eligibility, which is, as Chris has already been through already, who will look at what patients really are eligible for the study, and it's all done. 10 to 20 minutes, very, very easy, very straightforward, and I've helped, I've contributed. I'm not a big academic like some others on this panel. I'm not even a budding academic of the future either. I'm a delivery GP, service delivery GP. That's what I've been trained to do. That's what I love doing. I really have I love my patients. It's absolutely fantastic. I have great times with them. But this is how we can help, and this is how we can change things, not just for my patients, but for all your patients, UK patients, and internationally. I'll stop talking now, Gary. I'll come back to you, but I think that's my thought anyway.
Okay, and thanks very much for that, Nick. And obviously, you and I work quite closely at the college, and someone who has so much passion about research, and yet, as you said, you don't describe yourself, you wouldn't self-define as an academic, but it's really important to see how frontline GPs can really get involved. And I think that accessibility and then the translatability of the results that we're getting from the research is making a difference to the people that are sat in front of us and that we're dealing with on the end of the phone. And I think this is a unique opportunity, and we've seen a massive expansion of frontline GPs getting involved in research, which is something I'll pick up a little bit later with Simon and the work that we're doing with the RFC, just so that I'm now equal on acronyms with you, Nick. But I'd like to move over now and talk to Polly, because Polly, I think you've been doing some work into research that's looking at the wider impacts of COVID on patients and society generally.
Yeah, thanks, Gary. So I'm Polly Duncan. I am an early career academic based at the University of Bristol. And I'm also the chair of something called Pact, and so that's another acronym. It stands for the Primary Care Academic Collaborative, and it's quite a new initiative, but I think it's really exciting because it's basically the idea is for a network of people across the UK, particularly aimed at early career people, so GP trainees and medical students, who collectively take part in research projects. So you design a really good study, and then people throughout their different practices in the UK collect data in their individual practices. The data can be used in the practice level to identify sort of areas for quality improvement, and then the data is combined to answer really important research questions. And so that's something I'm leading on. In terms of looking at COVID, we're just about to launch our first Pact project, and it's focused on housebound patients. And one of the questions, it's actually funded as well by the RCGP, and one of the questions we're looking to answer is what impact has COVID had on housebound patients? And I think one of the concerns that lots of GPs have is actually that the health gap is perhaps widening. One of the particular issues is to do with the type of care we're delivering, doing more things remotely, more things by video, online, and concerns that actually some patients don't have online access. So looking at some of those sort of wider issues, that's one of the things I'm looking to do with my research.
Okay, thank you for that, Polly. And I think, again, talking as a frontline GP, that weekend back in February, where we sort of left practice on the Friday evening consulting in a traditional way and came back the following Monday with a whole bunch of new tools and new solutions for what was an emergency situation. And, you know, it's very reassuring to me to hear that people are doing the work just to see, is the evidence there? Is the new ways of working contributing to improvements in health for patients, or is it widening gaps? Because I think it's really important. If we were taking on any other new ways of working, we'd make sure we had an evaluation program in place, but this was all done a bit on the hoof and a bit quickly in the space of sort of 48 hours. So the sort of work you're doing is really, really important. You mentioned that you're an early career academic. How did you get interested in research? When did you first dip your toe in?
I think it was actually as a medical student, I would say. I was lucky, I did a great project and I had a fantastic supervisor then. So that was the first time when I just thought, oh, I understood for the first time what you can do in research, how you can make changes on a bigger scale, which I think is the thing that really excites me about research. So that was my first dipping of my toe.
Excellent, thank you. I want to bring in Victoria now. Victoria is one of my officer colleagues, one of the joint honorary secretaries at the college. And Victoria, I know you're passionate about health inequalities too. I just wondered if you wanted to take a couple of minutes to talk about the work you're doing with health inequalities and the importance of research to back up what you're talking about with colleagues at the moment.
Yes, thank you, Gary. So I'm Victoria Georgia Brown. I'm a GP in East London, academic GP in East London, and also the RCGP's Joint Honorary Secretary. Within the college, I lead on the Health Inequalities Group. So we have a group of GPs that are very, very passionate about addressing health inequalities or helping to address this very, very complex problem. I have an interest in thinking how these new ways of working that Gary touched upon, so especially the very fast move towards remote consulting during the COVID period has affected health inequalities, and what most importantly we can do in order to address any issues that there may be there. So the first aspect is to understand what is the impact, and the second is what can we do about this in order to address it. It's very important to do research. I was reflecting on the conversation just before that, how relevant, why is it that practices suddenly engaged so greatly with research recently during the COVID period? Is because we had an emergency and because the research that was happening was very relevant, very practical, and very high priority for them. And I think if practices really realize and GPs realize that the research outputs can really help them with their everyday workload, can really have an impact on them and also their patients and the quality of care they deliver, they will really engage with research much better going forward. So I'm hoping the health inequalities research that we are going to do is going to be equally relevant to the COVID-related research in terms of how you address the disease, the COVID disease, but also, as I said before, we need to look how this COVID pandemic, how we changed the way we work has affected our patients and also ourselves as well.
Brilliant. Thank you, Victoria, for that answer. It's becoming very apparent that, you know, people often have these ideas that academics and researchers are tucked up on the 5th floor of a big ivory tower and never get down to the front line. But I mean, I know, Victoria, you work in practice. Nick said he does as well. And Polly, you were saying earlier on that you combine your academic work with other responsibilities as well. So what does your average week look like? How does research and academia fit into your working life? I'll go to Polly on that one.
Thanks. So over the years, I've done different ratios in terms of GP and academic work. The ratio I've got at the moment is I actually just work 1 day a week as a GP, and I'm currently working 4 days a week in research. I've also got a young family, so I've got 3 young kids. So it's sort of juggling, lots of juggling, but it is doable. And actually what I find is the research makes me really enjoy my GP job more, because I'm constantly thinking, oh, why do we do things like that? And, oh, maybe we could do that slightly differently. And equally, my research makes my GP job more enjoyable. So I think it works really well. Okay, so it's that inquiring mind and that ability to relate what you're doing on your research to the people sat in front of you, which has got to be what we're aiming for when we talk about primary care research and the context in which it's done and the reasons for which it's done. One of the things that's been coming up in conversations recently is around long COVID. And you know, we're not just dealing with the immediate effects, but we've got to look at the long-term impacts of the disease in communities as well, and how we can help patients with this long COVID scenario that's emerging. Are we doing any work or research around that at all? Is anybody able to talk to that subject at all? Phil, can I bring you in perhaps, please?
Yes, thanks, Gary. Yes, I mean, it's become very clear, hasn't it, once the pandemic got going, that the long-term chronic effects of this illness are pretty devastating for people and can lead to long-term damage to organs, etc. So the NIHR has commissioned work to look into this. There's a big study called the FOSP COVID study, which will be looking at patients who've come out of hospital with COVID-19 and following them up for lots of blood tests, investigation scans to define the sort of long-term effects, but also to look at what interventions could be trialled in this group of patients to help them gain a full recovery. So there is some active, urgent public health work going on in that area, Gary.
Okay, thank you. And certainly from a policy point of view, that's something that the RCGP has been calling on NHS England for, to have discussions around how we're going to provide care for this cohort of patients that's emerging off the back of the pandemic that has these really disabling longer term effects. I just want to shift the emphasis a little bit now. When I came into post as an officer at the college, one of the parts of my portfolio was to become research lead, which at first I thought they were joking because there's quite a few profs kicking around the building, but no, it was true. And someone I've come to work very closely with is Simon DeLucian, who is really in charge clinical director of the RSC, another set of acronyms. So Simon, can I bring you in just to talk a little bit about what the RSC is and what's happened over the space of the last 6 months, because it's been a phenomenal transformation that is really advantageous to not just the research that's going on now, but the future of primary care research as well. Oh, that's £5 in the pot, Simon, because you're still on mute.
Story of my pandemic is talking to mute, sorry. But anyway, I'm Simon DeLucian. I'm also a GP, still doing 2 days a week in the same practice in my 34th year. And I've got to say to Chris, as we haven't spoken today, I've recruited 2 patients this week for principal. So it can be done, and we've all got to be up there and doing our bit. And if I may give my soundbite on principle before I come back to it right at the end, is I think Chris's message of randomise, don't prescribe, or prescribe, don't randomise, however you like to put it, is definitely the way we should be going in primary care. And I think it's such an important message. To answer the chair's question, I'm sorry to be slow to it, the RCGP, Royal College of GPs, has had a research and surveillance centre really since 1957, but since 1967, it has been involved in a national surveillance and been involved in flu monitoring and then flu vaccine effectiveness. And I became its third director in 2014, I think with 88 practices. And I think by the beginning of the year, we got up to 400 and something. And one of the things to say is that there's just been a phenomenal response from across the profession. I think we've now got 1,746 practices signed up, though there's a little bit of a lag in us being able to work with their data. So what we do is we extract data from member practices. We get it what's called pseudonymized because we've no interest in who the individuals are. And we produce weekly reports and we produce dashboards and observatories. I'd love to spend the whole of the rest of the meeting showing you, but probably the chair won't allow it. And we're trying to use this data for a number of purposes, which I use the acronym SQUIRE for. So we use data for surveillance, quality improvement, and we feed back to practices via dashboards and the like. The R is for research, and E is for education. And if there's a big message I'd like the college to be much stronger on, it's this whole idea that coding is caring. So for all of us as principals in primary care, if you don't code, you don't care. Because if you don't code data well, how can you have your performance and that of your practice compared with other people? And that high quality data also feeds into our ability to do research. And I don't know if I'll get the thumbs up or thumbs down from Gary not to go on too long, but we've used our network to look at community spread and who tests positive in the community for COVID, and found the people more likely to test positive are the same groups who are at higher risk. We've looked at mortality, both those with known COVID status and just in the excess mortality, and found this enormous peak between weeks 12 and 24 of this year. I mean, vastly elevated mortality in those over 75. But the most exciting thing for us, if I may return back to principle, the opportunity, which sort of I felt with my move to Oxford might come to the network, in a year or two, and the opportunity to try and get our practices engaged in principle and recruiting to this trial. We do produce for members a dashboard to get some idea of the number of cases that you're seeing. But obviously it's been challenging since lockdown to recruit to this, but we're now seeing in every region in the country a rise in COVID, which one's in one sense sorry about, but for principal and recruitment, it's a great opportunity.
Okay, thank you, Simon. I'm actually going to go back to Victoria in a second, just for a little bit more on RSC, but we've had a question on Twitter from Steve, who's asking, is 111 and 119 or test, trace and isolate pointing patients towards the principal trial? Chris, maybe I could ask you on that.
Sure, Gary. Yes, we've been working closely with the national NHS 111 line, and clinicians there do signpost to the principal trial. It would be great if they could also check eligibility while they've got access to patient records. But it started off with a great big flourish, and activity from NHS 111 is diminished, and we're hoping to refresh that. It's a very complex field out there that is very fragmented when it comes to regional 111 services. Some of them are provided by public provision, some by companies. Getting access to them, getting their clinicians aware of the study, explaining to them how they can help is proved really hard. So it's an example of how fragmentation actually has undermined our cohesion as a discipline as well. But we're working very hard now, and have been all along, with the Department of Health and Social Care to try and get to the clinicians on the ground. And this brings me back to a critically important point here about research in primary care. We all know about the recovery trial, fantastic study in hospitals, over 14,000 recruited, life-saving evidence has been generated. Now, we should be doing that in primary care. We've recruited about 910 people, but we haven't had the same traction as the hospitals. And one of the reasons is that interaction between a clinician and the patient that they're caring for should include, almost as a knee-jerk reaction, a built-in response to introduce them, to give them the opportunity to participate in research. And that needs to be embedded not only in general practice, but also in the 111 services, and in fact, anywhere where there's a health professional talking to a patient.
Okay, brilliant. Thank you for that answer, Chris. And just to remind everybody out there, if you want to ask us a question, if you can go to #TeamGPLive on social media or through the online members forum. We've got members of our team looking at the forum to make sure that we don't miss any of your questions. I'd like to spend the next few minutes. I'm just going to go back to Victoria just to ask if you've got any comments around the RSC, and then perhaps go on to Nick to talk about two things really. First of all, your role as clinical lead for research within RCGP, and then perhaps to answer a question for me, because the only other acronym I knew about research when I started the job was SAPC, so I'm hoping maybe you can talk a little bit about that as well. But if we go off to Victoria first, please. Victoria, any thoughts around RSC and its value to us?
Yes, I think viewers may be interested in actually going on the RSC website, the RCGP RSC website, and having a look, because it's not just the information around COVID. It's there is an observatory on workload, which I find fascinating to go and have a look what is happening actually with in terms of workload, and how many telephone consultations and how many face-to-face are we doing. It gives a very good picture of what is happening at the front line. And also, personally, I find, again, with my health inequalities hat and also interest in social prescribing research, there is a social prescribing observatory as well, which starts to give an idea of how are we doing in terms of social prescribing referrals, and what is the activity and work-related issues around that. So it's great data that we are hoping to use in order to understand better how to use these interventions like social prescribing better in the future, because Gary, I think you are a commissioner as well, and I have been involved in commissioning. With all these things, all these initiatives, you need to know what is their impact, what is their value, in order to maintain their funding and keep investing on these. So everybody thinks they are good initiatives, but unless we try to understand them and provide the evidence, we will not know. So I would encourage the viewers to actually go and have a look. It's quite interesting to see these, and they are almost live. They are updated very frequently, so it's you get a very good idea of what is happening on the ground.
Okay, thank you, Victoria. And I know that Simon spent some time with me, taking me through the dashboards and showing me exactly what sort of information you can pull off there. Did you want to add anything to Victoria's comments, Simon, around the dashboards and what people can see online?
Yeah, I just think one thing, one tiny point I just wanted to make was that I think it's so important for our future, and it does overlap with what Chris is saying about primary care research, is the future has to be, to my mind, bottom-up and professionally led. And we are the people to do that bottom-up, professionally led thing. And because to my mind, what happens is often anyone can pull out data, but can they extract meaning from it? And without the context of understanding primary care, I think it's extraordinarily difficult. So I do think we as a profession should be coming together, and I know we're multi-professional in primary care, but the profession in primary care should be coming together to really, really lead what we do with data and information.
And that data and information around workload and what GPs actually get up to is crucial. I mean, I sit in a lot of policy discussions in my role as Vice Chair for External Affairs, where we just really need that evidence of how hard we're working. It gave us the opportunity at the college to rebut the claims last week that perhaps GPs weren't as busy as some people would like us to be. And when we've got that hard and fast evidence, we knew we were seeing 1 million people a day, and we knew that 300, 1,000 of those were face-to-face consultations. And it's having that sort of data and information to hand that really allows us to push back when we're in negotiations and discussions with the other arm's length bodies as well. Nick, if I can come over to you, as I say, when I picked up the research portfolio as part of my role at the college, obviously we met with you as research lead. And can you just tell the members, you know, what is the college involved in research? Why have we got a research lead? And what do you see the main aim of your job is? And if you can just help me again, the SAP theme thing, which I know about, but if you could just remind me.
That's fine, Gary. Yeah, I think you drew the short straw, didn't you, when you got to work with me? You know, I keep knocking your door and sort of giving you a good shake, saying, research, what's going on with research? What are we doing for research? Why aren't we doing more for research? So yeah, absolutely. It's been a privilege, actually. So I'm clinical lead for research at the college, and lead on the research program, of which the college has an extensive research program, actually. And the college research is at the heart of the college. I think sometimes in the past, some people said, oh, how much research is the college doing? What's it involved in? Well, actually, it's involved with a massive amount. And the privileged position I've mentioned, I think, is amazing, because I've got to work with, obviously, the people on this panel tonight, which is fantastic. And some of them are sick of my face, I think, on Zoom and Teams over the past few months. But actually, it's not just that these guys, there's an amazing amount of academics, GPs I've worked with, and way brighter than me, I must say. So my role is there to really, I think, to really champion their research, work with them, engage them, and sort of see and assist them in what they can do, and really take UK general practice to a new level. I mean, that's what we're trying to do here. Part of the program is to SAPC, as you mentioned. So we work with the SFB. I'll throw another acronym in there, the Scientific Foundation Board. That's a big core part of the RCGP research side. And the Scientific Foundation Board is a funding structure that enable new researchers to come through. And I think that's really key to reinforce that tonight. So if you're a GP, you're sitting there in your practice, you think, I've got an idea. Well, what are you going to do about that idea? It's probably a brilliant idea. Some of my partners have actually come up with great ideas, far greater ideas than I can come up with. But they don't quite know what to do with it. How can we liaise with that? What can we do about that? Well, the SFB has a practitioner grant system allowing people to apply for a small piece of money, small financial income to try and get them to start, give them that time, that headspace to go away and have to think about that research idea that they've had and maybe take it somewhere. The SFB also enables research programs and research projects to be funded as well. And so Polly's mentioned that the RCGP is involved in that. That's where Polly and the Pact network became involved with the SFB, which is obviously a fantastic movement. And the big thing to say about the SFB, it's actually run in tandem with and in partnership with the SAPC, the Society of Academic Primary Care, of which Carolyn Shoe-Graham is the chair, and she's amazing, absolutely amazing, to be honest. Gosh, if you thought I was enthusiastic and a bit of a whirlwind, Gary, Carolyn is another level. Anyway, and I think it's been a privilege to work with her and see her at work is just fantastic, and how engaging she is, and how she sees not just senior academics and how they work and how important supporting the likes of Chris and Simon in their work, but also to the young researchers, the new ones coming through. There are so many amazingly fantastic researchers and GPs who are looking to really start their new careers effectively, and the SFB and SAPC is really important to deal with that. Another part of SAPC that the RCGP have worked with as well, along with SAPC, is the WISE GP. Again, I'll throw another name out there, so Professor Joanne Reeve. Joanne is just incredible again. And I think if she hasn't got passion, then nobody's got passion, I think, about research and engaging people and really seeing us as a profession and as a discipline for the specialists that we are. We're specialist generalists, or we're generalist specialists. Anyway, I think the WISE GP is really worth looking at. It's a fantastic website. If you just type in WISE GP into Google, it's there to sort of celebrate the GP as a scholar, the GP as that researcher, and engage you into the thought processes around how can you become an academic GP if that's what you wanted to do. We all know GP general practice is wonderful for the commissioning roles, the leadership roles, the family planning, the psychology, the A&E roles. Everyone's got a different role as well. Mine is research. I love it. I think it's absolutely fantastic. I love research delivery. That's my thing. I'm not there to write protocols myself, but there's some very clever people who are very good at writing protocols and love their trials. And my job, my role, I see, is really supporting them in getting and facilitating their journey through their success of their trial. Really, really important. That's the sort of SAPC side, and the WISE GP and the Scientific Foundation Board. We've talked about that. Another thing we should talk about is research engagement. The WISE GP there is to engage research, engage academic and new GPs and GPs of any stage of their career to be involved in research. And at the college, we're looking to do that as well. We have a big research engagement package, which we're working on at present. That's there to really, yes, we want people to realize, and new doctors coming through in F1, house officers, F2. Do they want to come into general practice? Great. Do they want to be an academic in general practice? Fantastic. It's to give them the options to see what they can do, what their career can develop into as time goes on. And we're at the college, really, I think that's really important to our members to really say, look, we are supporting you from your early stages as an early career GP right the way through, and then we can show you opportunities for you. It depends on what stage of your career, stage of your life, and what you fancy exploring after that. I think that's really important to say. We also work on Research Ready programs. So you're probably not aware of what the Research Ready program is, Gary, even though I smash your door down so I'll tell you about it so often. The Research Ready program is a self-accredited program where practices who want to engage in research, want to find out how to do research, they can then become accredited, and then they are research ready. It gives them the tools, it gives them all the tools to enable them to work out how can I practice, how can I get involved in research, and how can I deliver research at my site. Sometimes that's a really hard step to take for practices. You can sit back in your practice and you can think, yes, there's this research thing, I want to deliver a trial, but how can I do it? Well, actually, Research Ready is there to give practices that information, that resource, and show actually it's not difficult. There are so many straightforward studies like the principal trial, but lots of other trials, even pre-COVID, where they can do a bit of research, do a few trials, and actually see, no, this is not a scary thing. This is very achievable in my practice. And actually, I'm just happy doing a couple of trials a year in my practice, and that's how I'm going to do it. And Research Ready will support me in doing that. It's recognized and supported through the NHR, and it's a really important program that we run here at the college, and it's the only thing of its kind, as far as I'm aware, internationally as well. So it's absolutely a superb program, the Research Ready program. Look on our website, that's there for people as well if they want to do that. Another part of my role is, of course, the RSC and working with Simon and his team. What a phenomenal rise I've seen with the RSC, how it's come from where it was, and this amazing work on surveillance, and has done for many, many years, as Simon said. But now its growth has been astronomical, really, with what's happened with COVID. It really shows the primary care's response to what's happened during the COVID pandemic, and what a key role that we all have in this. And I would urge, again, practices who haven't heard of the RSC, have a look at the RSC GP, RSC website. Have a look. If you want any questions, please contact me. It's very easy to do that. And you can easily then join up, and we can take you through how to become a member. And if you just want to be part of that, that's absolutely fine. I think it's also key to mention as well, we're talking about research and data links and data. The RSC is one data organization. We've got the CPRD, the Clinical Practice Research Data Link, another massively substantial clinical data organization. I think Phil will back me up on talking about those. I think it might be very important to discuss those briefly now. And of course, we've also got Q Research in the UK as well, who are the amazing organisation behind the Q Risk resources that we all know and use almost on a daily basis in practice. I think I'll stop talking now, Gary, because I've probably talked enough for now, and you've told me off on that.
Excellent. No, Nick, I never get bored of listening to the passion, and it's not just about the research and the work of the college you're passionate, it's about that inclusion and getting it out there to the front line, and I happily listen to that all evening. I just want to go back over to Chris. Chris, did you have anything you wanted to add on to this part of the discussion?
Yeah, Gary, thanks. I was just thinking about the critical importance of research being embedded within primary care, and getting away from the view that research is an ivory tower activity for the guys in Oxford to get on with while GPs are delivering real care. And it's kind of combating that view of it that makes people like me also keep a hand in clinical practice. And almost the definition of a clinical discipline is one which generates evidence to support its own activities. We can't be doing with only hand-me-down care or hand-me-down evidence from hospitals. Like tremendous strides that have been made from the recovery trial in hospitals showing that steroids are beneficial in the very sick people with COVID. And we think, well, okay, that they've done that research. what do we need to do? But they also found that steroids don't work and might be harmful in the less sick. And perhaps the people out of hospital, we need evidence generated by us to support that care. But we need to be able to do it in a way which is feasible and easy in primary care. And we're getting better at this in the research centers and the Society of Academic Primary Care and so forth have been tremendously helpful in making sure that research is doable within primary care. And I just want to give you a quick story about a study that I led around acute exacerbations of COPD. And I was at Cardiff University at that time and sitting in my office in Cardiff University designing this. And wouldn't it be nice to know if we, it wouldn't be good to add this in, and it'd be great to know if that, and our case report forms got longer and longer and longer. And I was sitting in my practice in Mountain Ash one day and a patient came along that was eligible. And I thought, geez, I've got to recruit a patient into a trial now. You know, I thought, I'm badgering my mates all the time, you know, get me patients, get me patients. So in any case, I start recruiting the patient. 45 minutes later, I'm saying, which idiot designed this study? And then I think, hold on, mate, who was it? It was you. So in any case, I went back to the drawing board, sat down with what I might call rel GPs in Ponty, and we redesigned the whole trial, made it much more deliverable. And that's the sort of trial that as a discipline we're able to do now. National democratic low burden trials. And you know, as a discipline, I think we all need to kind of get behind this, embedded into our everyday care. And we'll be able to be doing, say, what the recovery trial is doing for hospital care. We'll do that for primary care.
Okay, thank you very much, Chris. I'm going to go back over to Polly because I think you said earlier on you're from an organisation called PACT or Pact. And we've had a question on Twitter again from Jane saying, could we give any tips on engagement? She's a research nurse. It's her biggest struggle. And I really want to explore a little bit further that idea of opportunities and particularly for non-academic GPs or non-academic nursing colleagues that are working on the front line. Perhaps you could tell us a little bit about how Pact is playing into that arena, Polly.
Sure, thanks. So one of the things to say about Pact is that it isn't just for GPs, it is for primary care is multidisciplinary, and it's for all of the different health professionals who work within primary care. And it isn't just for early career people either, it's for anybody who's a little bit interested in dipping their toe in research. And one of the exciting opportunities that's coming up is in the autumn, we're hoping to launch a call for some grassroots projects. So these are particularly from people who are non-academics. So we're looking for people working on the front line, seeing patients and thinking, oh, why do we do that in that way? To put together, we're going to keep it quite simple, not technical, and to submit an application basically. And the idea is we'll then look at all the applications, we'll pull out the best ones and provide those people with some mentoring. And one of those projects we hope to work up into an actual research project, provide those people with support, and then the project will be delivered by our Pact network, so by other people working across. So this is a real sort of grassroots, different way of working to the traditional model of research that we have in the UK.
Excellent, thank you, Polly. And I mean, inclusivity is something that I'm particularly interested in. I mean, if we just look at the panel tonight, sorry guys, but there's a lot of white middle-aged guys here. What are the opportunities like for underrepresented groups? I was talking to someone from the RCP and they were saying they don't have the representation from the BAME groups and also from people that practice in rural settings. So there seems to be a whole demographic that gets missed out. So what's the academic community doing to make sure it becomes much more inclusive? Who'd like to take that one? Polly, go on then. Great, thank you.
So I can say a couple of things that we're doing as Pact. So that's one of the things that we heard loud and clear when we first started discussing with primary care colleagues, this idea of having this new collaborative. People were saying, but you need to make sure that this isn't just an opportunity for those people who already have the opportunity, for those people who already work in the big cities. And so that's something that's really on our agenda. And with that project that I talked about on housebound patients, some of the people leading on that project actually work in some of the most deprived and rural parts of the country. And one of the things that we're trying to do is see if we can engage people working in those parts that actually have fewer opportunities for research in our research. The second thing that I'd say is one of our committee members, Dipesh Gopal, is very, feels really strongly about thinking about issues to do with Black and ethnic minorities and widening and diversity. And he's actually developing tools so that when we're reviewing applications for our Pact studies, we're aware of our unconscious biases and how you overcome those challenges. So we're actively trying to do things within Pact, thinking about diversity and those issues.
Excellent, thank you, Polly. And Phil, are there any opportunities through NIHR for people to get engaged with research?
There are indeed, Gary. Just picking up on what Polly's saying, I think it's one of been my key messages, and the message of the NIHR is to make equity of access to research opportunities right across the board, right across the country. And again, I keep saying, if you want GPs in a particular area, particularly in an underprivileged, deprived area, to be involved in research, primary care is the way to go in that area. So I think that's really important. And inclusivity in research studies for participants is particularly important returning to the pandemic. And we're working really hard in the NIHR to incorporate and invite in a culturally sensitive way BAME communities into, for example, vaccine studies. A lot of work's been going on to make sure that we have representative samples of people in research studies. But just to return to the inclusivity bit, we've got a third of all English practices recruited patients last year into CRN studies. So the people on this call who think they might want to get into this, they're not alone. And it was up to 50% a few years back. So we're trying to create opportunities for our specialty, as Chris has said, at every stage of the career development so that people can dip their toe into the water. And the NIHR has some excellent academic career pathways. They're more for career academics, which, as we agree, very few GPs will want to do that. But there are excellent opportunities available, and people on the call have availed themselves of that. But our approach is very much, as Nick says, through the CRN locally to work with your CRN colleagues for practices to get engaged, do research ready, get interested in research, perhaps do the principal study, which we're promoting tonight, and get involved in research and see if they like it. If they do like it and it lights them up, and they can go on to do some research themselves. And I think it's key to equal opportunities across the board for all GPs and their staff. Shouldn't forget everybody working in the practice as well, Gary.
Okay, thank you very much. Just one area I want to touch on is, do you remember back 6 months where everything was all about Brexit? Well, we're facing the exit from the EU. Is that going to have an impact on research? Is that going to make a difference to the way we're able to do things? Would anyone on the panel like to pick that up? Chris, maybe you've got an answer for that one.
Yeah, so a lot of the research funding that I've had has come from the EU. And the EU has had a far-sighted vision for research funding where it brings together people from many countries. And there are certain studies that can only be done internationally. And walking away from that is very bad. We did, for example, the ALICE study, which was of neuraminidase inhibitors for influenza-like illness in primary care. And we were able to recruit 3,250 people from 13 countries. And it's that kind of collaboration across the EU, multi-country, 13 languages, that allows you to get a study of that size to answer a rigorous question. Now, what I'm finding is that no one in these multinational studies is asking UK-based people to lead such studies for obvious reasons. And in a way, it's the quality of our science and it's our commitment to internationalism, collaboration, working together to solve international problems like antimicrobial resistance, like COVID, that will have to transcend narrow political nationalisms that's bedeviling our research. So, hopefully some of this gap will be filled in by the UK government, but I tell you what, we've got to stick to our values. We've got to stick to our collaborative approach. Primary care is an international thing, and people around the world need to benefit from our joint experience. So it's bad, But I think we have to really work hard with our colleagues to make sure that we mitigate it, and we still remain at the forefront of research internationally.
Brilliant. Thank you, Chris. Again, a really articulate and clear answer. So thank you for that. I'm actually going to move across to Simon again, if I may, please. And a question around RSC that's come in. It's saying that practices are obviously very cautious, and some of them feel quite uncomfortable around sharing data, especially with the GDPR rules in place. You've got 30 seconds to persuade me, as someone working in practice with those concerns, that I should sign up. What can you say to reassure me?
I would say we're very sensitive to what's in it for me. This bottom-up, professionally led way has got to be the way to do it. And we really, really do work hard to make sure that everything's as anonymized, as close to extraction as possible. But it is about being in this community where you can see how you're doing compared with others. And it's one of the routes in to this whole research picture we've heard about this evening.
Brilliant. Okay, thank you. Unbelievably, we're getting towards the end of the hour already. It feels as if we've been chatting for 10 minutes. This always happens on these webinars. The time flies past once we get going. I'm just going to come around the whole panel and just ask you one last question. What's some of the easiest ways to get involved in research trials? And again, if you can keep the answers short, because we've only got a few minutes left now, but if you had one top tip for the people listening out there who's saying, actually, I've been inspired by this, some of the passions rubbed off tonight, these academics aren't wanting to hold on to this isn't their domain, they want to share it, they want to spread it. It's about getting it into primary care, into the front line, doing research in that context of where we deliver care. What would you say? I'm going to start with Victoria.
I would say get involved with one of the studies, perhaps through RSC or through your local CRN. Get some experience in terms of being a participant in a study from a practice perspective. Perhaps do the Research Ready module that the RCGP advocates for. And then this will give an opportunity to people who have never had an opportunity to get to understand research, to really start engaging with it and understand whether they really would like to progress and take it further, and perhaps do their own research in the future.
Brilliant. Thank you, Victoria. I'm going to work the way around my screen. So I'm going to go to Chris next and then up to Polly, if I may. So Chris.
Well, it goes back to the point that if we as a discipline don't generate evidence using our own clinical care to improve our clinical care, then people will ask questions, are we actually singing for our supper here properly? So, pride in what we're doing, the importance of the question to our clinical practice every day, such as, if I give this person doxycycline with COVID-like illness, is that going to help them or harm them? So with that kind of question, we can answer it using our everyday resources in an easy, low-impact way. So I would say this, get involved in the principal trial. It's a good starter trial. It's a route in. It's easy to do. And it's going to really, help us, I guess, be proud of our discipline, be proud of our clinical care, and help our patients ultimately get better quicker.
Brilliant. Thank you, Chris. And Polly, your top tips?
My top tip, I'm a bit biased, but I would say join Pact. It's really easy to do. Just go to our website and click on Join Pact. All it means is that you'll be sent a monthly update of all the opportunities. So we have some really exciting projects that are definitely doable within a manageable amount of time, but you probably won't hear about them unless you join up for the updates. Okay,
thank you, Polly. And Phil?
Yeah, I mean, from my perspective and from the CRM perspective, go online, find out which is your local CRM. We cover the whole of the country and the devolved nations of similar systems as well. Contact the CRM, the primary care lead, the GP, talk to them, get involved and do the principal study.
Brilliant. Thank you, Phil. Simon?
Well, of course, with all complete lack of bias, I'm going to say join the RSC so you can fast track your way into the principal trial and the other things. About 70 to 80% of our practices are active with their CRN, which is, so we've got to build on the synergy. If I was to give my real tip, what I would say is in your practice, create protected time so you've got some space to do it. The way I managed to keep practice going, my thing was sort of persuading my colleagues to give one of my new colleagues, Ruth Danson, a little space in a quarter of a day on Thursday morning. So look, we've got to get Ruth enough studies in then to fund that in an ongoing way. But create protected time, because if you haven't got a little bit of time to read the principal thing or whatever, you just can never fit it into the day. So that would be my big tip I'd really urge everyone to go for, as well as the RSC.
Brilliant. Okay, Simon, and last but not least, Nick, and I'm a bit nervous about going to Nick because he never lets us go in the lift. He always makes me walk up the stairs, so he gets to chew my ear off for a couple of minutes longer. But we're in the lift today, Nick, so 30
Okay, seconds. Gary, I'm with you. Right, fine. So easy one for this one. As Simon just said, time is time. We obviously know practices need time to be funded. A lot of this, all these research trials come with funding. Really important to say that. We haven't talked about tonight. And finally, Gary, I will leave you with, it's quite easy to do. If I can do it, then you can do it, Gary. And then we all can do it. That's the key. It's not scary.
And if he says I can do it, then he really has got high hopes that anybody can do it. Guys, girls, thank you ever so much for joining me on the panel tonight. As I say, this isn't my area of expertise, but it's been a fascinating conversation. It seems to me that the opportunities to get involved are many. And we've heard, we've unpicked the acronym soup a little bit tonight. And thank you all for your comments and commentary. There's lots of information about research ready, the principal trial and things on the RCGP website. So feel free to go there and have a look. I'm going to bring things to a close now. Thank you everybody who's been out there watching. Thank you all for your questions through the members forum and on Twitter. Don't forget, we've got our COVID resource hub, which is where you can access all the latest data and some of the research that's been done through the pandemic, which really is helping to guide our clinical practice. If you're interested in getting involved further, whether that's with SAPC, WISE-GP, PACT, RSC, or any of the others we've talked about this evening, then we'll be posting some links on the forum and across our social media channels tonight to enable people to do that. Our next session for discussion will be around social prescribing. We'll be talking to GPs, to link workers and to patients about social prescribing, its value in the community, how it's changed as a result of the pandemic. So watch out for that next one. We'll be announcing the date soon. Enjoy the rest of your evening. Thank you for joining us. And once again, thank you to the panel. Good night.